very first webinar for this year. Today we have an important topic, prostate cancer, which is very important because it affects all of us, especially men, as we grow up. And I would like to welcome the presenters today who have willingly accepted to be with us to share the knowledge and skills. I would like to welcome Mr. Lindsay Thompson, Dr. Rose Thompson, Dr. Wanangwa Namero, and Mr. Brian Nkata. I would like to let you know that we are so greatly honored this evening to have you all presenters tonight. You have left your jobs, you have left your busy tight schedules, but accepted to be with us tonight. It's a great honor to us, and we want you to share the knowledge which you have, so that at least we should know how we can prevent this prostate cancer. We should know some bits of tiny details on how we can recognize whether we are being affected with this. And I don't want you to possibly take too much of your time because our schedule tonight is very tight, and I would like if we can start as soon as possible, so that maybe at the end of the sessions we should have enough time to ask you questions. Thank you very much, everybody, and I would like to welcome you all once again.
Thank you very much. Thank you very much, Patrick. Yeah, Patrick is actually on the road, so that's why we can't see him. So thank you so much for that, for being able to do that. So drive safely, Patrick.
Thank
so
you.
Just to reiterate what Patrick said, we do have a packed agenda, and we have a couple of key speakers. So firstly, we're going to have Dr. Wanangwa Clara Namelo. We're going to have Mr. Brian Kata, Dr. Rose Thompson, and Lindsay Thompson. I will introduce them as they come along because each one deserves the time to be introduced appropriately. Whilst I'm talking, can Dr. Wanangwa start getting her presentation up whilst I speak, please? You're more than welcome to share your screen. So Dr. Wanangwa Clara Namelo, she is a consultant clinical oncologist in the NHS, and she works at Velindre Cancer Center. That's in Wales, and I hope I've said that right. I will give her the chance to continue introducing herself, but she's not a new face to Muna. She's been on our platforms, in our webinars, and she's a specialist in her area. And Dr. Wanangwa is just going to talk about prostate cancer, risks, risk factors, signs and symptoms, investigations, and management options. Dr. Wanangwa, over to you.
Thank you. Hello, yes. Can you hear me?
Yes, we can hear you.
Lovely. And can you see the slides on the screen?
Yes, I can see the slides.
Lovely, thank you. And thank you for the warm welcome. It's always a pleasure to participate in Muna meetings, because I'm always amazed myself at how much I learn when I prepare such talks. So thank you so much. As you said, I'm based in Cardiff, which is in South Wales, and I work as a consultant at Velindre Cancer Center. I currently look after patients with lung cancer and anal cancer, but a few years ago, I was doing urology and I happened to do prostate cancer. As Sarah said, this is a big topic. So half an hour is really just an intro, but I'm hoping that you're going to get some useful things from this talk. Just trying to share move my slides. Okay, that worked. Okay, so we're just going to talk a few basic things about prostate cancer. We're going to have a crash course on where the prostate is located. We're going to talk about the epidemiology, symptoms and signs, what tests and investigations one needs to have, and what are the management options. And I'll try as much as possible to link in the setup in Malawi, and I'm hoping that people will be actively participating and asking questions, whether immediately after my talk or at the end, depending on what the chair feels appropriate. So the first slide on here, it just shows us where the prostate is. Now, it's always a bit challenging to picture talk to people who are of different backgrounds. So I've tried to make this as basic as possible, but for those who this is too basic, I'm sorry, but I'm hoping that we're gonna build the foundation together and at least get the main points in. So I'm just gonna take my video off. Right, so this slide basically just outlines the urinary tract in a male person. You can see up here is the kidneys. They're connected to two big tubes, which it goes into this big bag here, which is the bladder. And the bladder sits right behind the bone that you can feel between your right leg and your left leg, your hips. So that's this pubic bone. Behind that is the bladder. And just underneath the bladder is this tiny little thing here called the prostate. And the prostate on the other picture, on the picture on your right, imagine that you've sliced the person on the side and the person, you're looking at the person from the side. You can see up here, that's the bladder. That's the bone in front of the, your hip bone. And that's the prostate here. Okay. And the location is very important because you can see that the urethra, which is the tube that drains urine from the bladder to the outside, passes right through the prostate. And this image on here is just a magnification of that, okay? So what if you get this if you understand this, then the whole, symptoms and problems with prostate will make sense because of where it is and the structures that go through it. Now, it's a very small organ, but it is quite important, mainly in the sexual function in males. It has two growth spurts or growth periods in puberty, and after the age of 25, it continues to grow basically for the rest of a male's lifetime. Now, things are always happening in our bodies without us being aware, but at some point things do go wrong. And that is where cancer comes in. And there's usually no one specific cause of a cancer. It's usually a multiply of a number of factors that the system doesn't work and therefore cancer develops. But the bottom line is that there's abnormal growth of the cells or the components in the prostate gland, which form a cancer. And usually growth and what feeds the prostate to grow is the male hormones, and the main one of it is testosterone. Now, why is prostate cancer important? It's important because the incidence or the number of cases is increasing quite a lot. And it may be increasing because people are aware of the fact that there's now PSA screening that people can access. But also, we know that with age, people are living longer these days, and the incidence of prostate cancer does increase with age. On average, people from the age of 50, the risk of cancer starts to increase, especially in Black Africans. In Caucasians, it's slightly later, probably about 65, 70. Now, prostate cancer is becoming very common, and we know that current statistics indicate that in the UK, 1 in 8 men will get prostate cancer in their lifetime. And that is even higher in Black Africans because it's 1 in 4. So you can see that this is quite important for people of Black African origin. I haven't got the statistics for Malawi, but I'm sure you all know or have heard of someone who is suffering or has got prostate cancer. The incidence is generally increasing. I think people are more aware, people are going to hospitals, And with social media and everything else, we are being, people are sharing information. So this is an increasing problem. We will talk about risk factors. And these are important because these are some of the things we as people, we can talk about or try and modify, especially in our male colleagues. They can try and modify these things to try and reduce the risk of prostate cancer. But we know that being Black is a risk factor for prostate cancer. And it's understood that this is linked to the genetic makeup of Black African men. Unfortunately, most men present with aggressive cancer in our population. Apart from genetics, possibly our health-seeking behaviors also does contribute to this, because certainly in Malawi, where I come from, not many men like to go to hospitals just for a routine check. And therefore, when they present, usually it's because they are quite unwell. And because of all these factors, there's a high death rate from prostate cancer in Black African males. Age, we've talked about. Increasing age is a risk factor, and possibly because as our male colleagues get older, there's a likelihood of things going wrong when the cells multiply. There's also high risk of one getting prostate cancer if there's a family history. So if your father, brother, or son has got a history of prostate cancer, then your risk of getting this disease becomes reasonably high. Other factors include obesity or overweight or trunk of fat. Basically, if you're fat, but your tummy is particularly bigger, then there's all sorts of chemical or scientific evidence that increases your risk of getting cancer. And usually people of that predisposition tend to get aggressive cancer. And when they get treatment like surgery, you can imagine it's quite easy to get complications if you're of a raised BMI. Other factors that we know predispose not only to prostate cancer, but generally cancers is diet. So high fat diet, processed meats or red meats, high quantities of sugars, those are known to predispose or increase the risk of one getting prostate cancer. And therefore, people are always encouraged to have a good intake of fruit and vegetable and other healthy things that I'm sure you're well aware. There is no evidence that if you take certain supplements, that will reduce your risk of prostate cancer, because I'm aware that there's a lot of talk about, can I eat this, can I take that to reduce the risk of prostate cancer. Prostate cancer, cancer disease. If you lead a sedentary life.
Sorry, Clara, we've lost you there for a minute. I think maybe it's your network. Clara, can you hear me?
It is a protein or chemical that is produced in the prostate gland. And when there's increased activity in the prostate gland for whatever reason, including cancers, then you can detect this in the blood test. Now, it is also very important to, when you go to your GP or to your doctor and ask for a PSA test, to be aware that there will be other causes that will increase your PSA. And so when you go for a test, it's important that your clinician takes a good history so that they're able to interpret that PSA result without causing huge concern or distress. Now, why is it important to go for routine PSA test where you can? This is the reason, because in most men with early prostate cancer, they don't have symptoms. Now, the picture on your left shows a normal prostate and one prostate on the right to it, where there's a prostate cancer growth. And you can see that that cancer growth is actually outside of the prostate gland. Therefore, it's just sitting there. It's not causing any problems, and you won't be aware of it, but it will continue to divide and grow. And the other picture with the blue black background on the right, you can also see a normal prostate and a not so good looking prostate because it's cancerous. Now, if you get that at an early stage, then you're likely to have certain symptoms. And in some ways, if you have a cancer that is growing in this region here, where the urethra or the pipe is, then you're lucky because it's going to present itself quite early with symptoms of a blockage. So we're just going to talk about what are these symptoms of obstruction or blockage of the urethra or the urinary flow. If you think about the first picture where we talked about where the bladder is and the outlet being the urethra, and then where the prostate is, if there's a problem in the prostate and it's squashing the outlet, the urine will be obstructed or flow will be blocked. And therefore, when you go for a wee, whereas now, if we go for a wee, your brain just tells you, your bladder is full, please go and empty it. And you go there and you don't even think about it. Everything just happens automatically. When there's a problem with the flow of the urine, there are certain things that now you start to become aware you have to actively do to try and get your urine out. So you will notice that because there's blockage, men with this sort of problem tend to go quite often for a wee. And in the daytime, you may not notice it, but at night when you're sleeping, you may find that whereas you used to wake up once at night, you're waking up 4, 5 times, 6 times. And then when you go for a wee, you stand there, you can't actually just start emptying your bladder. You have to strain and you have to push. And even after doing that, the flow is not very good because it's like stop and start, stop and start. In fact, sometimes you push and the urine doesn't come out and you think, oh, I've finished. But immediately you feel that your bladder is full again and it's asking you to go back and try and like have another go at making a wee. The other thing you will notice is that whereas, like especially growing up when we were young, boys would stand there and have a competition and see who's able to wee the furthest. You may find that flow is all reduced, and sometimes you end up, either weeing on your feet or having lots of drops onto your feet. Occasionally, when there's proper invasion, usually of the surrounding structures, you may notice blood either in the urine or in the semen. Occasionally, people present with erectile dysfunction. But in severe cases, you can just present with complete obstruction where you want to go and empty your bladder, but you simply cannot because there's total blockage. And if that's not relieved quickly, then there's backflow of urine, which causes other big problems. If you think about that picture, because if the bladder is full and the urine can't get out, then there's backflow into those tubes. And then that's how the kidneys get damaged, because the backflow of urine affects the kidney function as well. So this is where the prostate is just in the prostate cancer is just in the prostate, but we know that usually cancer doesn't stay in one place, it starts to move. And the first place usually it will move to is the surrounding structures. Now, the surrounding structures in terms of the prostate is the bladder. So the cancer can go and start invading or eating into the bladder, or it can go backwards and start causing problems in the back passage or the rectum and anus. And you can start to have problems there. As I said, I treat anal cancer, and from time to time I get patients diagnosed with anal cancer, but when you look into it, you realize it's prostate cancer that's pushed or eaten backwards and gone into the back passage and causing problems there. Apart from the local spread, cancers tend to spread to other areas, and this is how people or patients get stage 4 cancer. So the cancer cells will move from the prostate here, they will go into the blood system, and therefore once the cancer cells go into the blood system, they will go everywhere where blood goes. So that's from your brain down to your toes. The same thing with the lymphatic system. This is another channel of fluid that goes around in the body, clearing things that are toxic to the body. The cancer cells can also go into the lymphatic system and spread through there, and that's how people present sometimes with swollen glands due to cancer. So when one has got advanced disease, what are some of the symptoms that they could have? General symptoms can include tiredness or malaise or feeling lazy, a poor appetite, weight loss, and just not feeling great, not feeling yourself with no obvious explanation. But in terms of organ-specific symptoms, then if the cancer has spread to the lymph nodes, you can get swollen glands, and these can be detected especially in the neck or the armpits, or indeed in the groins. Very commonly, prostate cancer goes to the bones, and people will just suddenly start presenting with unexplained pain, especially back pain. So especially for the elderly people who might have some of these urinary symptoms, and they start to present with pain that is not responsive to simple painkillers, and you can't explain it. That's one of the things when they go to the doctors, is this pain from something more serious. Sometimes people will go to the hospital and they'll have a battery of blood tests, including a liver function test, and they may be noted to have abnormal results there. That could also be from prostate cancer. Prostate cancer does spread to the lungs and cause problems there. And sadly, it can also go to the brain and cause all sorts of symptoms, confusion, loss of function, things like stroke and things like that. So we've talked about the prostate incidence, signs and symptoms, and the spread. So in someone where, you go to the doctor and the doctor suspects prostate cancer, what are some of the investigations one needs to have? So very simple test is the PSA. If that's raised and the history is suspicious, usually the doctor will do a rectal examination or examination through the back passage, because you can feel the prostate there, and there's certain characteristics that you can feel straight away when you examine the prostate that this is likely to be cancer. But the most important thing is to have a biopsy so that you can confirm the diagnosis. Blood tests, just so you can check out if there's any major chemical imbalance going on. Very important, if possible, that you get an MRI scan of the pelvis. This is standard in the West. I'm aware that in Malawi, you have to pay to get an MRI scan. But an MRI scan is important, especially this part of the world, because it will give you a lot more detail about what's going on around the prostate and therefore influence your management. also important, not only in prostate cancer, but in most cancers, is to get a CT scan of the body from the chest, abdomen, down to the pelvis, because you want to see how far the cancer has spread, and that will affect how you manage the patient. In some places like the UK, other schools of thought do routinely a bone scan, because the bone is a very common site for prostate cancer. There are also a number of fancy tests that one can have depending on where you are and availability. Usually after all these tests, the clinician or the urologist or whoever your doctor is will have information enough to be able to tell you what stage of prostate cancer someone has got. This slide just basically illustrates the 4 stages of cancer. To make it simple, stage 1 is very small amount of cancer only found within the prostate. Stage 2 is still within the prostate, but a little bit more widespread. Stage 3 is started to come out, and stage 4 is spread outside of the prostate and to the other organs that we've talked about. Okay, now this is a key slide because it's telling us about treatment options. Now, there's a lot of options if you're, for example, in the UK, and I suspect places like America as well, in developed countries, there's a lot of options for treating prostate cancer, which probably is not the case in Malawi. But the main thing you want to achieve in prostate cancer is to stop the driving factor, which is the male hormone. So you want to block that male hormone. And we do that by using different drugs, or in what's called hormone therapy. Apart from doing that, you can also remove the actual prostate, which is the target organ. So that's why people end up having surgery, because if you remove the prostate, then all these hormones, they've got nothing to attack. But the overview, or the most important thing for treating prostate cancer, is hormones. And what does that hormone do? Basically, you want to achieve a state where you remove the food of the cancer, and you can do that with chemicals. That's called medical castration. Usually, the hormone therapy is given in the form of injections. They're very easy to do here and very cheap. It's not the same in Malawi, because I know people do struggle even to get these injections for prostate cancer. Even with advanced disease, hormone therapy or these simple injections are helpful, and they will keep the disease asleep for a while, because we know that at some point the cancer will become resistant to the hormones. But apart from the hormone therapy, which is key, there's other things that can be done to manage prostate cancer. And we usually group the cancer into like risk groups. You stratify them into risk groups. So there are cases where your doctor will say, you've got low risk prostate cancer. And looking at different factors, your doctor might say to you, actually, your best option is for us to do what's called active surveillance. So basically, you chill out, you monitor with the view that you will go in with treatment at some point. Or sometimes if the doctor doesn't feel, that's usually in young people. For older folks with a number of medical problems, you go for what's called watchful waiting, the same thing basically. You know the cancer is there, you're watching it with frequent test and examination with the view that you're going to go in with intervention at some point. Usually, if you're intermediate risk group or advanced, then watching is not an option, in which case, if it's early stage disease, you can have surgery. There's different approaches for that. Or you can have radiotherapy. There's also different types depending on where you are for that. And as I said, you can also use hormones. So that's for early stage prostate cancer. For most of us, and certainly most of the people I know back home, unfortunately, they present with advanced disease or advanced cancer where it has spread to the bone, to the liver, to the lungs, and therefore you have to manage it because that's not a curable situation. So you can use the hormones, as I said, and in cases where the cancer becomes too clever for the hormones, then there's other things that can be used. There's the option of using chemotherapy. You can use radiotherapy, even if it's just to try and control some of the symptoms, for example, bone pain. And in developed world, like in the West, there's also all sorts of fancy target therapies that try and stop the driving force of the prostate cancer. But whatever the case, especially in Malawi, I do believe that the fact that you haven't got all these treatment options, it doesn't mean that people should be miserable, because at the end of the day, we need to try and treat the person from head to toe. And that's why there's the other talks are going to talk about supportive things, pain control and other things that can be done just to make life bearable for someone who's got prostate cancer. Now, I just put on there this concept of surgical castration. We have talked about medical castration, where we're using chemicals to stop the hormones that drive the cancer. Potentially, surgical castration can be used because that's quite easy to do. You go in as a day operation, you have the testes removed. That's a very powerful procedure because you're actually taking off the complete food for the cancer. And in cases like Malawi, where people are not able to get even the hormones that we think are cheap, I think that's something that we probably need to talk about a little bit more often. I know in our culture, it's probably quite difficult to even suggest that because it's got a lot of negative vibes or stigma for a man to lose their testes. It's got a lot of psychological and physical effects, but it's a thin balance between those things and trying to survive a cancer. But I'm happy to take comments or questions later about that. So in summary, I'm hoping that you are able to appreciate that prostate cancer is becoming a common problem. It's a major problem in Black Africans, and especially because we tend to present with advanced disease, therefore increased risk of death. We've talked about some risk factors, which I'm hoping that you will reflect on and think about how you can help either yourself or your family members to try and reduce the risk of prostate cancer. I think it's also important that we try and from time to time go for just routine medical checks, because sometimes those routine medical checks, they pick up something, and that something might lead to an early diagnosis of prostate cancer, in which case you've got a good chance of having a curable diagnosis rather than picking up things by chance or because you're unaware when things are advanced. I'm also hoping that from this talk, you're a little bit more aware of the symptoms and signs of prostate cancer or problems to do with the prostate. And you have an idea of what sort of investigation one needs to have to determine appropriate management options for prostate cancer. That's the main talk. Probably worth just mentioning that there is a very common non-cancerous problem of the prostate. It's called benign prostatic hypertrophy. people just call it BPH or an enlarged prostate. And most of these symptoms of blockage can occur as a result of this non-cancerous problem, but it's always important to get it checked out if there's any problems. Thank you so much. I'll let Sarah control if there's need to take any burning questions now or leave everything until the end. Thank you.
Thank you so much, Dr. Wanangwa. You have just set the ground with a very thorough explanation with regards to prostate cancer. I mean, some of the things that you've talked about, I didn't know. And the fact that prostate cancer is increasing, and the numbers, 1 in 8 men will get prostate cancer, but 1 in 4 Black men. Now this, dear audience, whoever you are, call your brother, call your husband, call your son, call your cousins, because that figure is very worrying. And we are aware that our men find it very difficult to go for health checks, to have these conversations. And this is something that could save somebody's life that you know. So next, I want to introduce to you a gentleman called Mr. Brian Nkata. Brian, are you there? Brian?
Yes, I'm here.
Yes,
I'm here. Can you hear me?
Yes, I can hear you, Brian. I don't know if you can get your video up, but very briefly, Brian.
No,
yeah, are you able to get your video up? Well, whilst Brian is trying
no,
to do
I'm
that,
picking up my daughter at school, and
it's difficult.
It's a bit chaotic. I'm picking up my daughter at school, so.
Okay. Right, Lindsay, are you in? Lindsay Thompson?
I'm in.
You're in.
Can you hear me?
Okay. Are you all right to do your talk now whilst Brian is picking up his daughter?
Yes.
Is that
No,
all right?
I can speak.
Are you all right to speak,
I just
Brian?
can't do video.
Okay, just
I meant the video, because I can speak.
Okay, that's fine. All right, thank you, Lindsay, for willing to do that. I will give Brian a chance. So Brian is currently based in the USA. That's why he's picking up his daughter right now. He's a human resources manager at a company called Compass Group in the USA, but he is Malawian. And he used to live here in the UK, Nottingham, and I've known him for years. Can I just please ask people to just mute their mics whilst we're in here? And he wants to actually share his story about surviving prostate cancer. So Brian, I know we've eaten into your time, so I'll give you about 15, 16 minutes if you can. Is that all right?
Yeah, that's fine. Yeah, that's fine. So okay. I'll start with can you hear me?
Yes, we can hear you, Brian.
Okay, so I'll start with my dad. Sorry about my dad. I lost my dad to prostate cancer in March 2019, and only to be, diagnosed with it a few months later myself, after his burial. Now, the timing was definitely made it worse. There I was, I just buried my dad, and then you're telling me that I have the same thing, So this was a little after March 2019. From that day on, I made it a point, to encourage my family and close friends and males to get screened. But I wanted to talk a little bit about Dr. Wanangwa Namelo talked a little bit about the PSA test and all the screening, options that are there. And I think she'll agree with me that, whilst the PSA can detect high levels of prostate-specific antigens in blood, it doesn't provide a precise diagnostic information about, the condition of the prostate. So it's like one to use in prostate cancer. Only a biopsy can determine for it.
Brian, we've lost you there for a minute. Yes, you're sort of fading in and out. Yes, I can hear you.
Okay, so she also touched on MRIs that can, help to better identify patients who are more likely to need a biopsy. Now, I've had all this done, mine was just a routine. I didn't have any symptoms. She talked about not there being symptoms. I did not have any symptoms whatsoever. It was just a general visit to my doctor. And then after that, I was supposed to see him 2 weeks earlier. Then when I told him that I didn't see him because I had gone to Malawi to bury my dad, he said, "Oh, I need to send you to an oncologist." So I went there, and indeed, that's when I was diagnosed. Now, I'm glad she had the presentation of where the prostate is located, because in my mission to educate my friends and family, what I found out was that a lot of men, sadly, did not know where or what the prostate was located. A lot, you talk about prostate and prostate cancer. A lot of them were thinking the crown jewels, and then you explain about the digital rectal exam. Everybody cringes because nobody wants, the thought of a doctor going in your bottom to look at you is, some find it understandably it's discomforting, but some find it I don't know, uncomfortable, of course. But I did what I did. I've talked to people I'm close to about it. Go and get checked. Now, sadly, not a single of them, we're talking 2 years now, not a single one of them has come to me and said, "Hey, oh, I did go to get checked." And like, "Oh boy, that was uncomfortable." Nobody has, because everybody's just too embarrassed to have it done to them. And then you ask them, most of them are married men, right? And you ask them, "Hey, what are wife's OBGYN visits?" And she probably has a male doctor too. And then they laugh, like nobody's taking it seriously. Okay, but I was like them too. The first time I had a biopsy, my doctor, my oncologist, said, I've always find my dentist very invasive, but you are on another level, and it had to be done. I had to get checked, and the one other thing that understandably men find it embarrassing. Oh, it's fine, but throughout my consultations, I was meeting with just my doctor, my oncologist.
Brian?
But not what to expect. Yeah.
Sorry, we had lost you for a second. Sorry, go on.
Okay. Right. So I was saying that throughout my consultations, my doctor prayed me on what was going to happen. But then come the day of the biopsy, and then in the room, boxing with 3 other female nurses that tells me, "Hey, don't worry, I do that practical." And I'm lying. I'm thinking, and you're gonna use me as a guinea pig? I'm getting embarrassed, right? I'm sitting there, lying there. I'm like, I don't know these people, But then, you know what? They're just doing the job, okay? They're probably gonna forget about me as soon as they about me. As well, I'm thinking to myself, what would make anyone go to school for this? But then I'm like, okay, I'm glad they school because they're checking me. Okay, so thank God they did. And so to Dr. Namelo and on all the other oncologists on the call, doctors, nurses, I think my auntie Annie Fankata is on the call, my mother-in-law Aunt Chira is on the call, I think my wife, anybody on that is in the medical field, thank you for your service. I had treatment in August 2020. I am now 20 months cancer-free. I am a believer, so I know that God had a hand in all this throughout this process. So all praises to God. I think Dr. Namelo touched on a little bit. I think what determines what happens afterwards, your age, your diet, and the stage of the cancer. Mine was stage 2. So I am 100% fine. The only reminders that I have are my doctor's visits, which used to be quarterly, for PSA checks. It's routine after.
Brian, we've lost you again.
Can you hear me now?
Yes, I can hear you now. Yeah, go ahead.
So I would just go backtrack a little bit. I said that I had treatment, I'm now 20 months free. I don't believe her, so I know that God has had His hand in all this, all throughout this process. So all praise God too, in addition to all the medical, that did. What the surgery? I'm stage 2, and I'm 100% fine. I didn't experience anything crazy. The only reminder of prostate cancer that I have are my visits to the doctor for PSA checks, which used to be, quarterly, but now they're every 6 months. Those are routine after prostate cancer treatment. Now, I would like to remind every man on this call, to go and who hasn't had, been tested. Your husband, please encourage them to get tested. I wasn't even 40 when I got diagnosed with it. The Dr. Namelo did touch on the fact that although a lot of men of African descent suffer disproportionately from prostate cancer compared to non-Hispanic Caucasian males, the truth is cancer does not discriminate. All men are prostate cancer. And don't worry about the evasive ways and techniques that the doctor is going to do to get you checked. It is worth it because early detection could save your life. Thank you.
Thank you. Thank you so much, Brian, for a very honest portrayal of your journey. And we praise God that you are cancer-free. And it's fantastic to hear from you, because when we're thinking about this topic, we're looking around trying to find a story of somebody we know from Malawi. And when I saw your story online, it threw me back, because I know of your age. I know how young you are, and it's unfortunate that we can't see you. And if people do see you, you don't fit into the typical description. Some of the descriptions. Yes,
okay.
There you are.
Can you see me now?
Hi.
No, I'm in my car with my son picking up his sister. So there was a lot of commotion, but yeah. So that's it was hard to share your story, your testimony. I have a dear, my family and I, my wife and I, have a dear friend who's battling stage 4 breast cancer. And I think I shared with you, Sala, that it was hard for me to share my testimony because in the back of my mind, I felt like I was gloating. Here we have somebody close to me that is, she's in hospice pretty much. And then I'm like, what am I doing sharing my testimony? It felt inappropriate. I actually had to talk to her. I said, hey, this is what I'm struggling with. And she says, Brian, go and stand on the mountaintop and share your story. And when she said that, she freed me. And then that's why I shared it on Facebook. But, you want privacy and whatnot. But I realized that it's selfish to keep something like this to yourself. But yeah, I am 100% fine and living my best life.
Amen to that. And I think I just want to share with the audience that Brian has actually gone on and started a business that's called God's Favorite. I think through his testimony, he realized that God has had, it was an epiphany in your life. So he's got a clothing company, as I would say. And I will share what you do with other people, because it just highlights your testimony that you've realized that you are one of God's favorite children, and he's watched over you and kept you. So thank you so much for for sharing your testimony. And I think when you've dropped off your little one, if you do have time, do stick around, because we do have a Q&A at the end, and I know that there might be people in the audience who would like to ask you some questions. And thank you for being brave. You are the first Malawian man to speak about this. So thank you so much for your bravery. It might bring other men out to share their stories as well. Thank you.
Ooh. Sala, you're muted.
So I was saying all of that to myself, was I?
Yeah, you did.
Oh, goodness me. Right. Well, I was just saying, thank you. A massive thank you to Brian for his bravery and for, yeah, just sharing his journey. And that's something that our Malawian men find very difficult to do. And he's the first Malawian man to do that in such a public platform. And I hope this will open the door to other men to start speaking up and start having a conversation about a very important health issue. Moving on, I'm just gonna pass the floor on to Lindsay Thompson. Brian, can you please stay on if you can? Later on, jump back in because we have a Q&A session, and I know that people might have some questions that would be directed to you. So please do stay around.
Yeah, sure. I'm here.
Okay, thank
I'm
you.
here.
Lindsay, I'm gonna let you introduce yourself. All I'm gonna say is Lindsay, I met Lindsay and his wife, Dr. Rose Thompson, about 2 years ago, and I volunteer in their fantastic organization that's based here in Nottingham. It's called Be Me Cancer, Against Cancer. And Lindsay is a co-founder, just as his wife is, but I'll let him introduce himself further and talk about the work that they do. Lindsay?
Okay, thank you, Sala, and good evening, everyone. My name is Lindsay Thompson, and I am now Chief Operating Officer for Be Me Against Cancer, and as Sala said, a co-founder. So what I'm going to do very quickly, if I can, is to run through the history of the organization and what we have accomplished, and also what we're hoping to accomplish in the future. Okay, so please move on. Okay, so what I'm going to do is briefly cover our story and then speak about the Hear Me Now reports and the branding that we now have as an organization. Okay, so the background of this is that why BME cancer communities in the first place? The Department of Health published a strategy for cancer back in 2011, and this is what we can quote from that report. It says that incidence and mortality rates from cancer are higher in disadvantaged groups and areas, leading to worse outcomes and lowering our overall performance. Therefore, the greatest scope to make rapid improvements is by focusing activity on the disadvantaged groups and areas. Hence, Black and minority ethnic groups were, in some cases, more than twice as likely to die from cancer in comparison to the white population here in the UK. So if you look at the date, we were established in 2009 as a community interest company. So we were ahead of the chase then, if I may say. Let me just go back. Right, so in 2009, we established a community interest company. It's called a social enterprise called BME Cancer Communities. And it was a response to the cancer inequalities that we identified at the time that was affecting BME, Black and minority ethnic BME, and low-income communities here in the UK. So then, based on published research and also professional and personal experience with cancer, our mission then was to address cancer inequalities within Black and minority or BME and low-income communities through developing and delivering services that were relevant. So such as raising cancer awareness in the community and amongst health professionals. We were addressing cancer-related health inequalities currently that was affecting those communities, and also empowering those community members to make informed choices about the services that were available at the time. These were some specific resources that we developed, we focused on increasing appropriate support for BME cancer patients and their cases through support groups, encouraging and supporting, the development of the dissemination of information, cancer information in other languages. And we also encouraged and support appropriate BME cancer research initiatives that we'll speak about a bit later. Okay, so our initiatives during that time, over the past 12 years, was very much collaborative, and we work with other agencies and statutory bodies. So here are a few examples of those that we worked with. So we have Macmillan, as you know, Macmillan Cancer Support. They're a very large charity. Irish in Britain is an organization representing the Irish community in the UK. Cancer Black Care, another charity based in London. British Heart Foundation, and they're not to do with cancer, but again, we know that Black people, high blood pressure and hypertension is really having a massive impact on our community. And also Prostate Cancer UK is another of those charities we collaborated with to deliver certain initiatives. University of Nottingham, a Nottingham City Clinical Commissioning Group, Nottingham Trent University, and one of the top ones is Genomics England with the 100,000 Genomes Project. Rose may speak about that briefly or mention that in her presentation. So these are a few of the organizations and powers that be that we collaborated with to deliver services during that time. The topmost breakthrough, though, was the Hear Me Now reports, and this was authored by Rose Thompson, Dr. Rose Thompson, who is my wife and also the chief executive. And the subtitle was The Uncomfortable Reality of Prostate Cancer in Black African Caribbean Men. And you've heard the previous speaker, outline the issue with prostate cancer, that Black men are at higher risk. And this report was launched in the House of Commons in February 2013 and presented recommendations on confronting that uncomfortable reality. That was followed a year later by the same title, but subtitled 1 year on. And this follow-up report presented compelling evidence to demonstrate that a concerted effort was needed to ensure that those at higher risk of prostate cancer can be identified and treated effectively. So Hear Me Now, which was the title of the report, became a nationwide campaign focusing on this issue in around 15 London boroughs and other cities, including Birmingham, Manchester, Leeds, Nottingham, and Wolverhampton. Now then, so what was the outcome of that? The outcome here is that because we were based in Nottingham, and we were raising awareness over a period of time, we began to, really ring the bell on the door of the local commissioning group here, the Nottingham City Commissioners, about the fact that they need to address the local issue with prostate cancer. And thank goodness we can say that at the present time, in terms of response to, detection and getting people into treatment, I think Nottingham is really among the leading localities at the moment. So what was the issue then of that particular report? The issue of that initiative was the prostate cancer risk assessment clinic. Now, when we were told, that we were going to run this project, we thought that the term prostate cancer risk assessment was not going to communicate effectively what we wanted to say in terms of getting people to respond. So we changed it to a more familiar term called check things out. Okay, so that's how, that's the speak that people would understand. Okay, so here are a few pictures of the nursing staff, the clinical staff who were on the left, who were taking the blood and doing the digital record examinations at the time, and at the right we have some volunteers who worked, who would actually attend the clinic in session, and sort of sat with them and encouraged them to actually, to tell them that, it's nothing to be afraid of, etc. Okay, so that was a major initiative that was initiated 2016 April it was, and we completed that in 2017 over an 18-month period. Do you wish to say something, Rose?
Yeah, it was 2017 to 2018.
Okay. Okay, that's fine.
And actually, the second report that I wrote, I will speak a bit more about it, was called
Yeah.
The Call to Action. In the UK, we're always collecting data, but actually nothing is done with it. So it's really important to us to use the evidence to get something done.
Yeah. Okay, so this is just a list of the local community groups and organizations that we collaborated with to deliver the clinic successfully. Friends and Brethren's Prostate Cancer Support Group is the first support group that we established here in the city. They're now an independent charity themselves. Okay, so that's the first. The second one that is not mentioned here is Sisters Against Cancer, that was established in 2018. Again, that's the kind of work that we did to ensure that support would be available to those who need it as much as we could. Okay, so these are some of the organizations and community groups that we work with and engage with to deliver that clinic at the time. And what I'm going to do is play you if I can, if you can hear the sound, 1 minute advert that we use to promote the clinic from men to attend. All right, so I'll try and play it for you.
What is the most common male cancer in the UK?
Prostate cancer.
Correct. How many black men will get prostate cancer at some point in their lives?
1 in 4, age 45 and over.
Correct. Why are black men more likely to die from the disease than white men?
It occurs at a younger age and is more aggressive.
That's correct. What is Check Things Out?
Prostate cancer risk assessment.
Correct. What threat should wives and partners use to get their men to check things out?
Pass. No, encourage him and attend with him if you can.
Correct. What should you not allow to stop you from having a risk assessment?
Pride.
That's correct. What is the golden rule about prostate cancer?
Check things out.
That is correct. What is the difference between a prostate and prostrate?
Prostrate is a position. Prostate is a condition. If you don't check your prostate, you may have to prostrate.
What is the most common male?
Okay, move on. Okay, so that 2018, 29. Okay, so at the end, that period ended at roughly 10 years of our existence as a community interest company. We invested our resources to make sure it kept going, and we delivered on those services that our initiatives we wanted to work on. But anyway, we decided that we would do a review around May 2018 to see look back and see what we've done, and look at the landscape to see how, what we need to do in the future. So having carried out that review, we identified a few things that we needed to really consider as our core services. So the first here is advocacy and support for patients and carers, locally as well as other areas, because of course, with the increase of improvement in treatments, more detection and so on, more people are surviving cancer. And also we identified the fact that people were not able to verbalize, communicate with professionals effectively. And we were supported by at least one medical professional who said to us, we need you as a bridge between, the patient, the person who has the condition, and ourselves to communicate to them. And so that was something we felt was a priority. The other, which I mentioned before, was support groups. We recognize that support groups are vitally important. Looking back from the first support group, Friends and Brethren, that was established in around 2012, I think over a 9-year period, if Rose may correct me if I'm wrong, that not one man from that group actually passed away as a result of the condition itself. there may have been one or two who passed away, but it was from other things, but not from prostate cancer. And so the support that was available in that environment, plus also, observed elsewhere, meant that we needed to actually make support groups a priority as well. So Sisters Against Cancer came out of that. The other thing is, as well, is that there was a lot of information or awareness raising about, pre-cancer, sort of awareness, risks and so on. But actually, post-diagnosis, after people have been diagnosed and had treatment, a lot of people relapsed, or their recurrences they weren't aware of, or it was overlooked by the health professions and so on. So we needed also to bring post-diagnosis information and awareness on the agenda. So these are the three top, what we'd say, core services that we felt we needed to actually focus on after that time, or after 2018. So, okay, I can try and go back. We couldn't continue, supporting this out of our own resources, as we had to do in many ways during those times. And we needed to change the structure of the organization so that we could attract the funding to take things forward. Okay, so we came to a conclusion that we needed to change the organization from CIC, a community interest company, and to make it into a charter incorporated organization, a CIO. And so that we could have the finance to fund and deliver those services that we felt were needed. Okay. Okay, so from April 2019, we changed from a community interest company to a charity incorporated organization. That was April 2019. And our objects are, our aims, the foundation of what we want to do. It says that to preserve and protect the health of people in particular, but not exclusively, from Black and minority ethnic BME and low-income communities living with or affected by cancer, by providing and assisting in the provision of, and these are two items, two top ones in this list, culturally sensitive and appropriate practical advice, information, advocacy and support services, and services directed to improving participation in BME cancer research and detection. Those are the two main objects that we embedded into the constitution of the charity. So, moving on, our core services then, we plan to deliver. These are what we plan to deliver. We will therefore deliver or achieve our objects through the following core services and activities. Provide an advocacy and support service for cancer patients and carers. Continue to establish culturally appropriate cancer support groups. Provide pre- and post-diagnosis cancer information and awareness. Promote a healthy lifestyle and personal well-being. Or promote healthy lifestyle and personal well-being. And encourage collaboration and support appropriate BME cancer research initiatives. A mouthful there, but basically we are planning ahead to not only to underpin and establish an organization that is effective, and relevant, not only now but in the future. Okay, so our first step in 2019 was to say, how are we going to
Lindsay, can I just come in here? Because I think, as this is about prostate cancer, what they really wanted to hear was kind of what came out of that clinic. I know that we've got this. We've kind of, I think they get the gist about the organization. You mentioned how many people were checked, and the actual reports and things that we got out of that. So, and the website, if we could do that.
Right. Okay. I'll bring the slides up now, a bit further. Okay, let me go further now then, in that case.
You see, Lindsay's the business person.
Well, just to let our audience know,
Yeah.
Dr. Rose Thompson and Lindsay Thompson are husband and wife duo. So you can see the dynamics there. We can tell who the business person is, and
yeah. So I'll tell you the story.
Yeah, Rose is going to tell us a story. So Rose is going to speak after Lindsay a bit later on. Yes, and she will give us are you ready? I'll give the floor back to you, Lindsay.
Yes, I think I've lost the presentation now. Okay, let me try and recover that.
Okay. Whilst Lindsay's doing that, I know my audience, you hear an accent coming out from Lindsay. You know, when he talked about friends and brethren and he talked about check things out. Could you just tell our audience where you're from?
Okay, so I'm from Jamaica. I was born in Jamaica and I came to this country in 1967.
Okay.
And I grew up in South Wales.
Okay, so you're Jamaican Welsh.
I'm Jamaican Welsh, that's correct, yes.
Okay.
Okay.
And is that the same for you, Rose, as well?
I'm Jamaican, but I was born here.
Okay.
In Nottingham, basically, and then worked in London and a couple of other places, in Westminster Hospital and a couple of others, but I will cover that when I come on. I just kind of wanted to
so what I'm going to do now, I'll just give you the figures for the clinic, okay?
Brilliant.
And then you can come on and finish off, all right? Yeah. Okay, it was a bit further down on that. Right, let's do that. Okay, can we see that?
Yes.
Positive outcomes, yes?
Yeah.
Okay, right. So that slide was a bit further down. So what we did I think we started up with one session a week, every other week, and then it was each session we had 2 sessions eventually. But anyway, the number of sessions that we had, because this was a pilot actually, to see how people would respond. Right, we just, there was this idea that Black men weren't going to sort of turn up to the clinics and so on. So it was a pilot project, all right. And so it was planned at around, guesswork, how many people may turn up? I think perhaps 10. They didn't expect that. But over 33 sessions, over 311 men attended, dropped in voluntarily, no appointments. They just turned up, right, for their assessments. And from that number, 291 were tested. So that was an average of 9 per day per session, which wasn't expected. On one occasion, I think the highest attendance on one day was 28, and that day they had to go back to the hospital to get extra resources to do the blood test and so on. So the only time when the figures fell was during the very cold winter periods, which is understandable.
Can I also come in there as well? We already had the prostate cancer support group running, and we'd already found over 30 men. So the figure would have been higher, but those men then came in as peer support for those who were afraid to have the tests and actually came in. And we changed it from we actually did it at the African Caribbean National Autistic Center. And initially the room was very big and it was very clinical. So a building beside it that they owned came up and it was like a house. So we made the downstairs like a sitting room, and we had drinks and things, a good receptionist, and actually those men came, and actually there were 2 or 3 of them that came, that whenever a man came and was feeling a bit nervous, they actually spoke to them, and we had prostate cancer awareness videos running as well, plus me.
Yeah, okay. So definitely at the end of the period, when we checked the statistics, they said that there were definitely 9 men from that group definitely had prostate cancer or diagnosed as having prostate cancer, but there was another 19 who were suspect, showing signs that they needed to be, at least something was going on, and they need to keep to watch them. So really, effectively, we're looking here at lives, of changes, positive outcomes that we didn't necessarily, expect how it's going to go. Unfortunately, in fact, one of the discussions we had after that was that why would not the commissioners recommission this kind of a project? But when the statistics, which we don't have here, shows that at the outset, for example, of awareness about prostate cancer in Black men, I think it was about 27% were aware. There was a kind of a pre-project evaluation of of survey of what men knew before the clinic was set up. But by the time the clinic was over and they checked again, the actual awareness was in the 70s, rather than 27, right? So if you look at that statistics, it shows that it proves the point that the awareness raising, it wasn't just the sessions. We went into the community, we raised awareness. A lot of activity went on to ramp up the actual, outcome from that project. Rose, you're going to say something?
Yeah, can I just say that it was really important for us to have people who look like us actually doing it. Originally, they were going to send 2 nurses. One was white Irish and one was white British, and one was male. And it soon became clear that we needed a Black nurse, and we knew one. So we asked for that one. And we also thought it was really, really important that people like Lloyd, who's photographed there, Lloyd is actually a part of our team, and he won't mind me saying that he has just been diagnosed. He's actually Jamaican, been over in Jamaica during the pandemic, finding out what is happening to men who can't afford treatment. How are they coping with it? And he was put on active surveillance. And many people don't understand the Gleason score. I'm so sorry that I couldn't come into this earlier. And what I do with the men is I will say, because often they will try and explain it, but they don't understand all the medical terminology that they're being sent, especially now. And I told him to bring his paperwork with me. And fortunately for him, his Gleason score, which is the number of samples that they take from the prostate gland, I don't know if it was covered, they can take in the UK probably about an average of 10 to 12. Which they do when they're awake, but they can also take 20 if they want to do it more detailed. And basically it's how rapidly the cells are dividing. They take two samples that they're rapidly dividing and actually look at the average. And it's between 6 and 10 are the main numbers. So the closer you get to 10, the more rapidly dividing the cells are. And when he came to me, he bought his paperwork. When he was first tested, where they put him on active surveillance, his Gleason score was 6. So they said they just actively watch him. I'm always concerned when they do this with Black men, because in our experience, their prostate glands tumors tend to divide more rapidly. And within 2 months, when he went back, his Gleason score had gone up to 9. So they then decided that they would go ahead with treatment. He chose to have his prostate gland removed. But I was at the, I don't know where people are actually listening from. I actually attend the meetings. And some of the men who had radiotherapy were having side effects. I'm a radiotherapy radiographer. They were getting some bleeding from the back passage. Not all, but it needed to be dealt with by the late effects team. And also we heard that they were thinking of increasing the size of the area treated. And one thing I noted is that men who had early stage treatment had not been offered the HIFU, they call it, it's ultrasound treatment, which has been actually approved by NICE in the UK, but not one of the men were offered that. So we will be taking that back to urology and finding out why not. The only man who'd been offered it was a man who was treated in London. Often we find that the further away you get from London, you don't get the same services. So there was less awareness further away, which is why we decided to be in the Midlands as well. So it's really important to understand what the Gleason score is as well. Perhaps that can be explained another time, but also to, if they say, and they seem to be putting most men over the age of 70 on active surveillance and waiting until their PSA goes up to 20 in the UK. But we are kind of on that as well, making sure that if they have new symptoms, that they actually do go back. It's different in different countries. We have a lot of catching up to do here, but actually, as Lindsay said, 300 odd men were tested. We had the GP lead on cancer who was BME. We had a Black nurse and an Irish nurse because they work very closely together. In Nottingham, we have one of the biggest mixed populations, mainly Black, Caribbean and Irish, because they were both discriminated against in the early days. So working together now, all those men who came, the ones who are under urology remain under urology, but all those men who came, their GPs were notified and they're being checked every year now. That was not happening in the UK before, and it certainly isn't happening in other cities. So it's a result, and it's saving lives. So we really haven't lost anyone for a while. And Lloyd was the one who came to me to actually start the support group, the one that was photographed, because he used to go to the African Caribbean National Artistic Centre funerals all the time. That was when we found out that the men had died from prostate cancer, because nobody was talking about it. So it's really important that we actually do something about it and not just talk about it and just do endless research.
Okay.
So I'm going to be very quick because I think.
Just go ahead now. Just continue. Yeah,
So I think, Rose, I'll let you introduce yourself because it's a natural flow, so that you can have some time to continue. You go ahead.
Yeah, so I'm sharing screen. Yeah.
Yeah.
I'm just going to quickly go on to. It's very few slides because I tend to like to tell the story. Let me see if I can get it up now. Slideshow. I'm really sorry about this, but we're so busy at the moment. We are actually supporting quite a lot of patients. So my slides aren't the most perfect ones. And I normally have more for more pictures in them, but we really are busy. So
Rose, I can't see your slides.
Oh, right, I've got it up. Mr. Thompson, do you want to come and help me? I'm in the other bedroom. Yeah. So I'll just end this show and go.
That's fine. Are you going to go on Mr. Thompson's one?
Yeah, he's not got mine, so he's coming to do mine, but I will talk in the meantime. I don't want to make sure it's not on, it's manually, yeah. So I'm going back to, do you want to set up for me? So as I say, my name is Dr. Rose Thompson, and I'm not that bothered about titles, to be honest, but from the current slide, please. Just go back to sharing. I'm just going to take it down and see if we can get back onto Zoom. And yeah, sorry about this.
That's absolutely fine. Whilst Rose is sorting that out, just to let my audience know, if you do have any questions, please put them in the chat. We'll pick them up during the Q&A time. And one thing I'm thinking about is myth busting. So if any of you are aware of any particular myths associated with prostate cancer, could you put them in the chat? And we can also pose them across as a question, because as Malawis, and I think as Black people, we have so many things that we associate with prostate cancer, and people have these weird associations, and it would be nice to utilize this opportunity to myth bust as well. Yes, we've got you, Rose.
Oh, great. Right, so I'll go from current slide then. Right. So yeah, I'm going to use my own. So as I said, I am chief executive. I don't use titles most of the time, but I actually gave up doing a PhD to do this, and I'm a radiographer. And I'm received multiple awards, but I don't do awards usually. But I've realized since watching the film Hidden Figures that we need to kind of shout about what we do, because we have people coming after us. And thank you everyone for allowing us to be here. So I hate the term BME. I don't like it very much. I don't like very much either, because it's not a term that we gave to ourselves. So I always called it Be Me, put yourself in my place. And so that's why we changed the name to Be Me Against Cancer. So that's me, but this is my story. Family history of breast cancer. I lost my mother at age 47 in 1976, 6 months after finding out that she had breast cancer in my 3rd year of actually learning to be a radiographer. I come from a family of nurses, so that's why I was quite keen to be here as well. Let me go back up. So this is my mother. I'm a twin. You can have a guess at which one that I am. But my sister is on the right and I'm on the left. She looked like my mother and I looked like my father. And my mother was Jamaican. When she had us, she was, I think, about 30. And she didn't talk about it. Now, my mother was very, very articulate. And we found that the men were not talking either. Sometimes their sons didn't know they had cancer until they got it themselves, prostate cancer. So she was praying for divine healing. And sadly, she didn't want treatments. But in 1976 in the UK, to be honest, even if she'd had treatment, the outcomes were not very good. And the reactions were pretty awful as well. So that was devastating because we didn't know anybody who had cancer, because cancer is primarily a condition that affects people over the age, I used to say 65, but over the age of 50. So when my twin sister was diagnosed in age 34, again, it was many years later, and because I was 19 when my mother was diagnosed, and she was early stage. It was just a lump in the nipple. She did well, and she was fine for 6 years. I found out later on that she'd actually had 2 miscarriages within the 5 years, so that may have surged the hormones, but it did return, but her GP didn't spot it. It returned in the same place that prostate cancer can return, in her back, the middle of her back. And the GP, and she thought it was just because she was going to the gym. Now, she was into everything, keeping fit, food combining, purifying water, the whole thing about diet, but it was actually because she was late diagnosed by her GP. And with my younger sister, but my twin sister was 6 years, and then she was treated and another 4 years. But it was mainly because of that late diagnosis. It's really important that we get early diagnosed with prostate cancer and any cancer. And my younger sister actually was diagnosed at the age of 42, again, early stage, and it came back in the same breast. She was not treated as it was recommended to have radiotherapy, and the breast care nurses missed it. So again, she had another 2 years, but it's devastating when these things happen. And what we want to do is stop the losses, get people not just talking about primary cancer when it first starts, but actually to be aware of secondary cancer when it returns. And that's what the men weren't aware of, particularly, you know, around the pelvis, the hips, and in the spine, which is common for prostate cancer. So I was diagnosed in 2015 with stage 3 breast cancer because the tumor I had was in an unusual place, sitting between the breast and the chest wall, and it couldn't be felt. But from then onwards, I've been on a mission to show people that actually, if you understand cancer, if you get help early enough, even if it recurs, you can survive and you can thrive. And we have many people with different types of cancer, but as Lindsay said, we have stopped the death rate in Nottingham from Black men with prostate cancer. The only one that I know of came to the support group late, and it's very much about support and men supporting each other and telling each other what the symptoms were. Like Lloyd, who's just been diagnosed, he wanted to know what happens if you have it removed. He didn't want, you know, radiotherapy, even though he is a pensioner. So I am currently on immunotherapy tablets and hormonal tablets. I'm not tied to a chair or anything. I recurred in my spine, but actually 1 dose of radiotherapy and going on to immunotherapy and continuing with it has actually controlled it. So you can survive the same with prostate cancer, and prostate cancer has a good outcome. Now, one of the things that people don't realize, that if you have a family history of breast cancer or prostate cancer, the gene that causes it, and we don't like to talk about genes, but it's a reality. You know, we have friends who are scientists, they see them, they image them, and a lot of the work was done in London, in St. John's Wood, with the East European Jewish population to find out about breast cancer, but then they found a gene for prostate cancer that actually looked like cancer of the ovary. They're called BRCA genes. Meaning breast cancer. So there's breast cancer 1, breast cancer 2, and breast cancer 3. But we found the same gene that was causing breast cancer looked very similar to what caused ovarian cancer, cancer of the ovary, and also prostate cancer. So where I thought that the breast cancer in our family was coming from the female side, actually it could be coming from my grandfather's side, because you get 50% of your genes from your mother, 50% from your father. And so now there's more attention given to the fact that if somebody has more than one family member under the age of 50 affected by prostate cancer, that the women need to look out for breast cancer as well. We need to be aware of the links. And since we were involved in the 100,000 Genomes Project, and Lindsay talked about collaborations, when I say collaboration, we actually approach and challenge and actually ask questions if there is no BME involvement in research. And if we need to know information, like the 100,000 Genomes Project was, the human genome was already mapped, but they wanted to map the cancer genome, you know, to find out what drove cancer. And so in the UK, it was a global thing, and I bet most of you don't know about it. It was actually to find 100,000 samples and actually look at them for diverse cancers and rare disease. And actually within a couple of months of actually finishing that project, we recruited as many people as we needed to, who were BME diversely, working with Leicester. We found that some of the new treatments and new diagnostic tests were coming out. And one that is about to come out is the Gallery blood test, which detects 50 types of cancer, not all, much more accurately than other screening tests. And it means that it picks up fragments of cancer DNA. And it is actually detecting things like pancreatic cancer and bowel cancer, the ones that tend to be detected very late, more accurately than even some of the solid tumors like prostate cancer. And so it's being trialed at the moment in the UK, and there will be buses going around the UK recruiting people who haven't got cancer. I am really keen to have evidence, because it was the evidence in my report that actually challenged our local commissioners who commission action. They could not argue with the evidence in my report, so we fought to get the funding to run that community clinic, and it's now saving lives. So just to show you that just as the men in the UK, on average, the black men were being diagnosed, Black African and Black African Caribbean men, from the age of 45. But the youngest man that's been diagnosed in Nottingham was 40, and he was African. He wasn't from Malawi, but he was just studying over here, and our men supported him. and are still supporting him. So this is really important because with Black women, they are the youngest to be diagnosed. If you can see the columns, the white women on average were 62, and then the Black women were youngest at the age of 50. So that means if they are average 50, they're being diagnosed in their 40s, and some in their 30s, like my sister. So it's the same with the Black men. We've heard Brian's story, and thank you, Brian, for sharing that some of the men are now in their 30s. We were not seeing that before. I've been treating prostate cancer and raising awareness about it for years. Problem with family history is that some people get younger and younger. And I've just been on BBC Breakfast Television with one of our MPs who's just been diagnosed with breast cancer, and one of the women there was 26 with no family history that she knew of. So we have to talk about family history in both. So I'm not going to talk about my allied health professional. There's a shortage. So many GPs were closed, 50% down on referrals. So we are no longer picking things up as early as we should. So early detection and diagnosis is negatively affected since the pandemic. We were 50% down on GP referrals, so people are coming very late, even with breast cancer and prostate. And it's really important as nurses and even, you know, those who are diagnosed, that we educate people about the symptoms and actually support them to get help. I've had to call GP practices for some people just to get them to refer them when they should have done since the pandemic. So we're about to do, and Sala's been really great with the teaching about advocacy, being a patient advocate, and actually meeting them, you know, at the clinics, and when relatives can't go, we've been there, and really just making sure that they get the service that they should get. So education must be increased in order to save lives. I'm not going to go on much more. We have the Hear Me Now report on our website, bmecancer.com. All our reports are there that you can refer to. And we've also got the men's stories in the Hear Me Now reports, and the call to action is going on. Leeds has had a clinic as well. We've got Leicester interested. London's had a clinic. Sir Frank Chinigwanda, is he a sir now? Professor Frank Chinigwanda, Nigerian consultant urological surgeon, had the first clinic, but funding is a big issue. So that's why we're now a charity. So thank you for supporting us, and thank you for inviting us. And do go to the website if you need references, or if you just want to hear the men's stories, then it's in those Hear Me Now reports. Thank you.
Thank you so much, Rose. Rose and Lindsay do amazing and incredible work. I mean, I take my hat off to them. I support them. I do volunteer work with them, but the work that they do really needs to be supported. And I'm just going to put this out here. I'm going to ask Lindsay if you can just type again your website, because what Rose has said is that what they're doing is charity work. And I'm going to use the acronym that we used to use years ago, FUBU, for us, by us. What they are doing is putting into practical, in a practical environment, systems and places where our people can go and feel safe. And there was a key word that she used, that she wanted people who look like us. So the nurses, the doctors, to just make sure that people feel comfortable and safe, because that's one of the key reasons and fear that people have about going into hospital. So for those of you who get a chance, go onto their website. There's a donation page there. Please donate whatever you can to ensure that this work continues on, because it can be your brother, your sister, your mother, your friend. It can be you. And when you do need that support, we want to make sure that Be Me Against Cancer is there. And as Muna, we are supporting your work, and we want to continue to have a relationship with you. This is just the beginning. So thank you so much for your fantastic presentation. And that link there between breast cancer and prostate cancer, I didn't even know it was there. So now you're opening up a can of worms, Rose. We need to do another session. Let's do another session around breast cancer. So everybody just watch this space. We'll talk about it a bit later on, but this is how discussions happen.
Yes.
Because when you don't see the link, now we know that there's a link. We need to have that discussion. And in our community, we need to have that safe space where we can have this discussion. So there was 1 or 2 questions that I had in the chat. Can I get back everybody up? Are you ready to stop sharing your screen?
Mm-hmm.
Yeah, I've got Charlotte. Charlotte, have you raised your hand? Do you have a question, Charlotte? Charlotte, you can unmute yourself.
Yes, I don't know whether it's a question or a comment. I just wanted to say I attended a session on prostate cancer a few months ago, where they're talking about relationship between good gut bacteria and gut bacteria and bad gut bacteria and prostate cancer. That is in relation to the castration-resistant prostate cancer. So what they were saying was when you give them the hormone therapy and then they become resistant, well, they stop producing the testosterone. The bad gut bacteria now takes over the production of testosterone. And then they did like a trial where those people who had good bacteria, the cancer stopped growing. But those who had bad bacteria after the hormonal therapy, the cancer kept on growing because the bad bacteria now took over the production of the testosterone. So they were talking about maybe trialing probiotic yogurt to try and increase the good bacteria to prevent their castration resistance. So I don't know if
that's a really good point, Charlotte. I'm really pleased that you brought that up, because I come from a family, my great-grandmother was the midwife in Clarendon in Jamaica, in rural Jamaica, and they did reduce the death rates of mothers and babies, but by cleanliness and using herbs. They couldn't afford to be treated. So we really are quite keen to see, I would like to see more medical herbalists, which is actually a qualification now that you can study for in the UK and probably has been everywhere else for a long time, actually working within the NHS so that when people come and say, can I take this with the treatment, that they get an intelligent answer instead of, well, you can't use this and you can't use that. At the moment, I actually tend to question things, and gut bacteria is really important. In fact, healthy eating, one of our directors, Rupert, is a nutritionist. So we encourage healthy eating, but I think there's a lot of research to do, even in soil. Did you know that there is bacteria in soil that actually can get into the inside of the MRSA infection cell and actually yam it out, as we say in the Caribbean, eat the insides, and then it explodes and then it moves on to the others. So that Nottingham University is actually looking at developing the soil bacteria. And we already know that people who are gardeners and have dogs and whatever, their immunity is better. So gut bacteria, it's basically been talked about for a while, but it's really important. And even if you're going into hospital, we used to recommend that, you know, you have probiotic yogurts before you go in, just to help with that. But then people who are on chemotherapy, if they have one of the side effects of immunotherapy, for example, the one that I'm on, is it reduces your white cells. So whenever there was a risk of infection, I would basically speak to my consultant about having a break. I'm due to have a minor operation. We have a break. And we try and keep the immune system up in other ways. So that's really important.
Thank you, Rose, for that. Just wanted to ask a quick question around COVID, because we've all just lived through 2.5 years or so of COVID, and we just want to understand, what impact has COVID had on people who have cancer, so prostate cancer or any other cancers? What sort of impact has that had?
Lindsay, do you want to answer that one? We've actually done a survey, and it's on our website, and we actually surveyed Black cancer patients and their carers. So the whole report should be up there, but Mr. Thompson will have put it up there because I don't do IT very much.
Yes, okay. So there's the report, which is the patient experience that is actually on the website. So statistically, I haven't got information, but if you go on to the report section of the website, you can actually have you can download that straight onto your device. Speaking statistically, though, what in terms of the impact of cancer and COVID, the Macmillan, one of the most recently produced reports by Macmillan is that there's a cancer backlog, right? Which basically means that, you know, there can be more later presentations as a result, effectively, goes without saying, and so on. So again, that's one, there's a knock-on effect, and also the actual the services which were once available and rolling normally are now, you know, stop-start, or there's a shortage of staff and stuff like that. So really, we have to get on to, you know, raise the profile of cancer awareness, particularly among our people, as much as we can.
We were personally affected, and I know that many of you were as well. I lost my stepbrother and stepsister. My stepsister had sarcoidosis, an autoimmune disease. She lived in Croydon, Lewisham, went into Lewisham Hospital, straight into ICU, never came out again. 3 weeks later, she was gone. The morning she passed, we think that her whole family caught the infection from the carers coming in to the home, because she didn't go anywhere. She was caring for a 89-year-old mother. And then the rest of the family got it. Her brother, we thought was fine. And the following night, he passed with it. We think he had an underlying cardiovascular condition. So we've lost many, many people to it, but it was the report has come out that it was because of the inequalities for people working here. Black and brown people tend to be more on the front line, and all sorts of things have come out of the report to show that things were not okay. And our report actually echoed that, and the lack of trust.
Can I add another point to that? Because part of one of the common themes that's coming through communications I've had with people is that they're in hospital and they're very, very ill, but the health staff saying, well, no, you don't look ill, because the physical complexion doesn't change, doesn't manifest the fact that how really unwell someone's feeling. Even my sister, very similar, she said she, you know, when she was on her last breath, sort of less she felt she was on her last breath, and the nurse said, well, no, but you didn't look ill.
Yeah, and the oxytometers, as we've heard in the news, the thing they put on your finger, it measures differently for brown skin. So normally when your oxygen levels fall below 92%, that's not good. But if it falls to 80-odd%, you've got a problem. And we were registering, was it 2 above that?
Yeah.
So by the time people got into hospital, because they were asking, you know, checking their oxygen levels, and this has probably been going on for years. We're just finding out some of these things now, that they were actually in crisis already before they even got into ICU, but they were being registered as having higher oxygen levels. And also, can I just say, if you have sickle cell anemia, if you have a thalassemia, whatever, my sister has alpha thalassemia, and she had pneumonia, which is usually what COVID went on to produce. And she could not, her temperature was 40 degrees, so she was a bit paranoid, but basically she wouldn't keep the mask on, and she couldn't get the oxygen in because her red cells were small and they were not keeping the oxygen. And I had to stay with her there practically all night, because they said if she didn't take it in, she'd have to go into ICU. She was in critical care. And it was through sheer like being big mother to my sister, saying, you will put that oxygen mask on, because she kept taking it off and her oxygen, they couldn't find the antibiotic. Eventually they did, and we just had to pray, because that's how I saw her oxygen levels falling, mainly because her red cells were so small. So if you've got any of those conditions that make you have anemia regularly, you're fatigued, you're breathless, then there seems to be more of a lack of vitamin B12 as well. So make sure you have your vitamins, everything, because it's important. Vitamin D, really important. Lack of vitamin D is contributing to things like prostate cancer and also to multiple sclerosis. We've seen a bigger increase, which is more common in the Northern Hemisphere. Scotland has the highest levels, but we're seeing an increase in Black people. In more, one of our members, her sister had it, now she has it. So please take your vitamin D, and you need more than white people.
Thank you, Rose. Clara, Dr. Wanangwa, you've got your hand up. Do you want to comment?
Yes, please, if that's all right. Thank you.
That's fine.
Great talks, both, and thanks to Brian as well for sharing his story. I just wanted to comment on the COVID issue. I totally agree with Rose that there's been a lot of negative impact all across the board, really. But generally, even before COVID, I think if you're Black or Asian in the UK, generally, it is difficult to get a GP appointment. And with COVID, it became really crazy. And even after COVID now, people are struggling. And generally, I say to my mates, if you don't feel well, you go and bang at the GP's door until they sort you out. You do not accept to be sent back or be ignored, because that is usually what happens, unfortunately. I think it takes, you almost need to persist for you to be heard. And, if you don't feel well, just persist and put your foot down and get help. So that's what I would say. Number two, I think in terms of cancer pathways with COVID, lots of crazy things have happened. Waiting times, as Rose said, the whole concept of early diagnosis and treatment is gone completely out of the window. Certainly in my clinic, I'm seeing a lot more younger patients with advanced, horrible disease. And they require a lot of time, a lot of investment to manage, which is a big challenge. So that has really been unfortunate, but hopefully we've learned important lessons. And if we ever get to a point like this again, I hope it doesn't happen again. Maybe we'll do things a bit better.
And can I also encourage people to start support groups? Because it's been really, really important for people to be supported. They're being told that they've got cancer. I spoke to a woman last week who, on her first mammogram, she'd had what she thought was a cough. She'd been trying to see a GP. She had to cry to see her GP. A GP listened to her chest and said she's okay. And then she has this mammogram, and she's told by letter she has to come on her own. And when she gets there, the nurse says, "Did you bring anyone?" She says, "No," the letter said, because admin is going to pot as well. And it turned out she'd not only got breast cancer, that she'd got, which had already spread to her bones and her lungs. And she was devastated, nobody with her. You need the support. And, there is support in some of the charities, but we often send our people to existing support groups, and they come back and they say, "I don't identify with that." So that it is not hard to start a support group. You start with one person. Wayne was our man, prostate cancer, lost his dad at 65, 2 weeks after going into hospital. Everybody diagnosed him. And then Wayne found he got it at 45. And he came to us. We called our first event Too Quiet, Too Long. And he came to us and said, "I want to join you to raise awareness." And we started it with him.
I think the key things that you've mentioned there, support and prayer. which is something that culturally, as Black minority ethnics, we always have faith. We have faith in something, and we are community based. And we are seeing that people are suffering alone, especially with prostate cancer. How can you encourage our men to get checked and encourage them to come forward, just so that we know that they're safe? I want to throw this to Brian first. Brian, are you still there? Brian?
I'm here.
Yeah.
I'm still here.
So how can we encourage our men to come forward?
I mean, I would say what I tell my friends is, listen, these doctors and nurses, that they're not keeping count of how many bottoms they're poking. If you think that, you know, the after work, and they're like, how many did you do? This is their job. Okay, don't take things personally. Go there, get it done, and like I said earlier, they'll forget about you when you leave.
Mm-hmm.
You know, so can you hear me?
Yep, I can hear you. Yeah.
Can you hear me?
Yes, Brian, we can hear you. It's you.
Okay.
Can you hear us? Yeah.
Yeah, I can. But
yeah,
you know, that's what I would say. Just don't take things personally. You know, it's their job. They do this every day, and get it over and done with.
Mm-hmm.
Yes.
Rose, you know, you spoke about 300 people came forward, and one of the largest people group was 28 when you did your research out in the community. Has that continued? Has that pace continued, where people are coming forward and getting themselves checked?
Yeah, the younger woman was 26. That was on. You can see that on BBC iPlayer.
Mm-hmm.
I supported Dawn Butler, who's just been diagnosed with breast cancer. We were talking about the difference when you're Black. You know, like the woman who's just had bowel cancer, end of life, she's just raised 2 million in 2 weeks. We tend to be trolled and racist and all sorts of stuff. But I tend to ignore that and just get on with what we do. I just think that the age group is going down. We used to say that between 5 to 10% of breast cancers and prostate cancers are family history. I think it's more now, and I think it needs to be rechecked. But I think it's really important to understand that whatever age you are, that you know your body. I was just typing, please do not accept a telephone conversation if you need to be seen. You do not have to accept a telephone conversation if you have symptoms and you need to be seen. And we are now seeing what we call, they used to call it comorbidity with in hospitals, where you get more than one condition. One of our men who had prostate cancer, Elijah Israel, he had ulcerative colitis, which is can make people more prone to bowel cancer, as can Crohn's disease. And Elijah Israel got the bowel cancer screening kit through the mail, basically. You just have to do, nobody likes to touch their poo. We dress up as toilets to raise awareness about bowel cancer and say, look behind you, because it can just be a little pink in your poo. But he had thrown away the kit twice. In fact, we just did a food, nutrition and cancer conference that we will put up onto YouTube. And he said he threw it away twice, and the third time he did it. And he found he'd got early stage bowel cancer. He got over prostate cancer. Nobody wants 2 types of cancer at the same time, but we're actually seeing that now. And then diabetes on top of it, and high blood pressure and all the rest of it. And please, please, if you've got sickle cell anemia and you're having treatment, or you've got a blood disorder, lupus is another one. My brother-in-law had that, and he was in construction and got lung cancer from asbestos. Many of our men have worked in construction, so they need to be aware when they were working, particularly in the 70s, if they were exposed to it, particularly if they were a roofer. So, but I feel he had lupus, and that was not addressed. My cousin's wife had breast cancer and had sickle cell trait, and people are saying, well, it's not the same. Actually, some people can have the trait and get symptoms, and if they're not addressed and they've got abnormally low hemoglobin, it should be between, this is the red cell count. They say between 11 and 13 for a woman and 13 to 15 for a man. I had a man who had beta thalassemia, who had prostate cancer, couldn't understand why his red cell count was 9. This was when I was working in the radiotherapy department. He got beta thalassemia. So I said to my colleagues, look at this. Do you know why this is? Not one of them knew what beta thalassemia was. And if you ask many of them now, they don't know what sickle cell is either. So, you know, you must let them know if you've got any underlying conditions, because they need to be addressed. And if you're on chemo and it drops your blood count down even more, or if you have a large area of bone treated in radiotherapy, then, you know, you will be thrown into anemia. So, and you'll need a blood transfusion. And some of the groups that don't agree with blood transfusions, the Jehovah's Witnesses have actually worked here to develop bloodless transfusions as well. So if you come from a group that doesn't do transfusions, you can ask about bloodless transfusions as well.
Thank you for that. We're going to go on for another 5 minutes. I'm aware that we've gone off over a little bit, but we started a little bit late, and I am grateful that our audience is still with us. So that means that they do want to continue having a conversation. And I don't know how long Rose and Lindsay can stay with us. So I'll just continue until you say you can't do it anymore. But Clara, before you answer or make a comment, can I also throw another question that would actually be directed to you? Because you alluded earlier on in your presentation about there was a query, does ejaculation decrease prostate cancer, and how does it do so? If that happens, how does that happen? I've got you on mute, Clara. Yeah.
Okay. Okay, lovely. So there's one thing I was itching to say. I didn't feel like I would sleep tonight if I don't say it. But basically, there's another darker side to prostate cancer, especially in Black African men, that we've talked about PSA and how it's used to point in, you know, GPs or doctors into the suspicion of prostate cancer, and also for monitoring response to treatment, as Brian said. But there are also cases where actually people who have prostate cancer, but the PSA stays normal. So that's an even more dangerous situation to be in, because if you're not right, you've got all these symptoms and your PSA comes back as normal, you will be passed as normal when actually things are developing and things are becoming more serious. And usually those tend to be, you know, cases where you have quite aggressive disease. That's just something I wanted to highlight, that PSA can be negative in someone with prostate cancer. Then coming to the point about frequent sex and ejaculation. There have been several studies that have been done, no firm scientific evidence, but the belief is that possibly during ejaculation and sex, there's some toxic chemicals that come out in the semen, and perhaps that's what's the protective effect. And reading deeply into it, even the article seems to suggest that there's perhaps a difference in the quality of the semen, you know, when it's through sex and through just normal ejaculation, like masturbation, for example, which obviously then opens up a whole can of worms. But perhaps more importantly, the article seemed to suggest that perhaps these are usually young men who are, their lifestyle or confers them a benefit or lowers their risk of prostate cancer, because probably they are more active and they exercise a lot. And we know that sex is a physical exercise in itself. So perhaps that's the link behind it, rather than you know, being the fact that, you know, the more sex you have, then you get protection from that. And then the other question obviously is, how often is often, how frequent is frequent, to say, okay, this is enough to give you benefit. it's all very up and down, but I found it quite interesting because these are one of the myths that, for example, back home, you hear guys sharing and saying, oh, if you do this, you'll be all right. If you do this, you'll be all right. When actually there's no scientific evidence. May I just take the opportunity to answer that question in the chat? It says, why does PSA remain normal when cancer is progressing? Okay, so in this, I'm assuming, okay, so two examples here. There are times when you have prostate cancer, and because of the increased activity in the prostate, there's increased production of the PSA, which is detected in the blood. And therefore, when you get treatment, you have a reduction of that production of PSA, and therefore you see the drop in PSA, indicating a response to treatment. And then there are times when you get to a situation where the hormones or the treatment is not working anymore, and it's not suppressing the activity in the prostate, and therefore your PSA starts to go up, showing that things are now starting to get worse. So that's one or two scenarios. But in the scenario where I say that you can have prostate cancer, but your PSA does not rise, it's just the complexity or the genetic makeup of the particular person, where there's activity going on, but actually that activity, it does not translate to a PSA rise, which can then be detected in a blood test. So that's how a PSA test is done. So you go and have a blood test at your GP surgery, but there's specific things that you can also increase a PSA. So for example, sexual activity or anything that stimulates the prostate will give a force rise in your PSA. So don't go and have a PSA test the night after you've been intimate, because that may forcibly raise your PSA. And also, if you've got infection in the prostate or in the waterworks, and you've got inflammation or prostatitis, that can increase your PSA. And therefore the GP will find it difficult to interpret whether that's that or cancer. And also if you've had an examination of the back passage for whatever reason, for example, if you went into your GP surgery, you had an examination of the back passage and then subsequently you have a PSA, there's a chance that your PSA may be high because the prostate gland has been massaged and stimulated.
Thank you so much, Sarah. So what I'm going to do, I'm just going to have two more questions. I'll have one question for Brian and one for, I think, Rose and Lindsay. And then after that, I will give each one of you 1 minute to give me an elevator pitch, just your last words in 1 minute to sort of sum up what we've heard here today. Brian, the question to you, I think maybe this individual might have missed your presentation. They're asking, why did you get checked for prostate cancer? And at what point do they do a digital rectal examination? Sorry, Brian, you're on mute.
Oh, I didn't get the first part of the question.
It's why did you get checked for prostate cancer? And at what point did they do a rectal examination?
So I mean, I had a routine, physical with my doctor that I was supposed to go in April. But then when I lost my dad, I went to Malawi. And then when I came back, after the physical, he's like, oh, I was supposed to see you a few weeks ago. What happened? And when I told him about my dad, that's when he just said, hey, I think you need to go see an oncologist. And he actually calls it an accidental find because he said, had I not told him that I had just lost my dad, things would have been worse. From that point on, I went through, hey, go drink loads of water, to him checking my prostate and then sending me back home, go drink lots of water and come back. So he's checked me twice. I've had that exam twice. At which point he was like, okay, we need to do a biopsy. But I can't remember if it was the doctor that talked about, sometimes they want to monitor you you know, but when he did the first check, it's like, I'm not sure, go drink water, oh, come back, oh, I'm not sure. And then eventually it's like, all right, let's do a biopsy.
Okay, can you just do you understand the reason why you had to drink water? Did he give you reasoning behind it?
Yeah, I think someone mentioned about, you know, sometimes you can just have an enlarged prostate. That doesn't necessarily mean that, you know, you have, it's prostate cancer. But to be honest with you, I couldn't tell you why. My mind was just all over the place, because having lost my dad and you're telling me you think I might have cancer. So whatever he was doing, if he told me go run at night, I was going to run. I didn't know why he was telling me to go drink lots of water. So, but you know, eventually when he decided to do the biopsy, then that's when he got the results, and you know, but yeah.
Okay, thank you for that, Brian. Rose,
No problem.
Yeah, thank you. There was a question that started, but I think the individual didn't finish. They were talking about you linking up with other, I think, charitable organizations, or I think Black or BAME charitable organizations that are doing similar work, so around sickle cell and so on. Is that something that you do, just to clarify for them?
We've been doing it for many, many years. And I think what was deeply disturbing after the first lockdown was there's an organization called Ubele based in London, and they do research, and they surveyed a lot of BME organizations, and they all said over 90% of them said they would be out of business after the first lockdown. And it's actually happened. We've seen it. You know that we actually just had a bit of lottery fund for 12 months to do the advocacy project. Otherwise, we might have had to close our doors. We've had to give up our offices. Our office, Cancer Black Care, had to close the office they've been in for over 40 years. I got calls from one of their support groups because they'd had to let that go. And so we've been having people join us from different organizations. We have Can Survive UK in Manchester. We have the Hugh Dwyer Inspirational Foundation in the Midlands. And we've all been connecting, and we've been supporting patients on Zoom, but it's very difficult to do. Professor Elizabeth, I've actually typed a message response to that, Lyndon, so I hope you see it. Professor Elizabeth Anyon Wu, who some of the nurses may know, she was practically single-handedly raised awareness about sickle cell and got it into the NHS, but the NHS doesn't do it as well as the community. So a charity called Oscar was started. We're very active in Nottingham with that, and I supported them both. My colleague headed up the sickle cell service, and since she moved on, I haven't heard anything from the NHS sickle cell service. I believe one of the non-BME nurses took it over, but Oscar they did get some lottery funding, but they expected that they would get some more to carry on the project, the health project they were doing. But it's all too often the plug is pulled after they get the first funding, and then of course they can't carry on. So we are carrying quite a few organizations at the moment and supporting them and collaborating with them. We're going to collaborate with a few to raise the BME participation in the Gallery blood tests, the one that detects 50 types of cancer, because if that is what it says it is, and I know the doctor who's actually leading on it, Dr. Sarah Hyam, it means that you can detect it earlier. You can see who's got the fragments of DNA for prostate cancer, say, or for breast cancer, and then it's those people that go on for further tests. So it means that there'll be fewer people having to have biopsies, and it will be more accurately detected. At the moment, 9 out of every 10 breast lumps that are found through mammography, which is exposure to X-rays, are not cancer. Now, statistically, that's not cost effective, but it puts a lot of people under stress who haven't got cancer. So, you know, I think we need better tests, and I think a blood test is what people are used to anyway, not that they can find my veins, and I'm sure a lot of you have the same thing. We need to have better ways of actually accessing Black people's veins as well, because I've had terrible problems with it. You know, just warming. If you drink plenty of fluid before you go and have a blood test, if you warm yourself up, and I'm asking professionals not to sit patients under a cold vent, which they tend to do, then you are more likely to get the blood. If you're cold, if you are dehydrated, then the chances of you getting a successful blood test are less, particularly after you've had treatment. So please take care of these things. And we know that some of the things that are happening to us, it's decades of stress. We used to think that, you know, every baby was born with a blank sheet, apart from, you know, the obvious inherited conditions. But actually, we now know we are studying epigenetics, us Black people, because epigenetics is when you get tiny changes through the generations that actually cause some of these conditions. I mean, why have Black people got more hormone producing cells? You know, Frank Chinigwanda told me that some Black women in their 20s, that they had more hormone producing cells than they should have. And it's hormones that drives 80% of cancers, and it's hormones that drive prostate cancer.
Thank you for that, Rose. Wow. I think my take home from that as a professional, like you said, was if we're taking bloods, to make sure that our patients are warm, that we're not sitting them under a vent, that we encourage them to drink, so that we are not causing you more pain during the process. And it's a distressing situation. And not just that, I just like to encourage any healthcare professional on this call that if you ever come across a patient or somebody who's come into your care who states that they're not feeling well, listen to them, be their advocate, because that's what our job is. We have to be the patient's advocate. So fight for them to make sure that you find out what's going on, because as we have heard here today, there's some things that are undetectable, and some things will do all these tests, but they may not show, and yet the individual does not feel well. So I'm going to close in the next 5 minutes. I am giving my 4 speakers a chance to just sum up in 1 minute what this whole session meant. And if there's anything that you want us to take home today, I'll give you each 1 minute. I'm going to start with Dr. Wanangwa. Clara, are you still there? Clara? Okay.
Hi, yes, I'm still here.
Yes. In 1 minute, are you able to sum up today?
Yes. Great talk. I think very informative. Bottom line is prostate cancer is a problem amongst our men. Let's be proactive and raise awareness and get checked out, because that's the only way we're going to get early diagnosis and try and reduce the bad outcomes that we currently have. I will quickly answer the question in the chat about the PET scan.
Thank you.
So PET scan work by detecting active cells. Generally, you get an injection which goes to cells that are active, and they light up, and if they're in abnormal places, the doctor says, oh yeah, that's cancer or not. Now, the tricky bit with prostate is that sometimes those cells, although they're active, they're not active in the same way as the, sorry, my son is just distracting me. So you can have prostate cancer cells being deposited in certain areas, but not picked up by a normal PET scan. So some centers will actually do specific PET scans. They're called gallium PET scans, or something called something PET scans, but basically they're specific PET scans that are targeting or trying to pick up prostate cancer, which is usually missed by normal PET scans. The other reason PET scans can miss cancer is the size of the cancers, because if the spots are really small, sometimes the PET scan cannot pick them up. So it's important that you interpret your patient's information, not based on one thing, but as a whole picture, to try and work out what's going on. But I've really enjoyed tonight. I've learned a lot, and thank you for organizing this. Thank you to the other speakers, and thank you to everyone for listening and sharing.
Thank you. Brian, quick 1 minute, what people can take away?
Hey, go and get checked. It doesn't hurt. You lose nothing. Just please get it done. Like I said earlier, early detection could save your life. But yeah, that's all I can say right now. And I wish everyone the best.
Thank you, Brian. Lindsay, Lindsay, you've got 1 minute to take away.
Hold on. Yeah, okay. Can you see me again? Right. I don't need a minute, but just one thing I could say in a few seconds. Yes. A few years ago, I came up with a formula for success for any activity we're going to do, whether it's to do with your health or anything. So I just want to leave this point. It's I use a mathematical equation. So V plus M times A equals US. Vision plus mission times action equals unique service. Can you see that? No. Did you see that? Did you see?
Yes, yes, we saw it. Thank you. Sorry.
Okay, so what we're saying is that if you know, you've done a great job in putting this event on this evening, right? So if we collaborate, if we invest in this, then we're going to improve the service, and we're going to be here a long time rather than falling, you know, by the wayside. So let's invest in what we have and keep on doing a good job. That's what I want to say.
Thank you, Lindsay. Rose?
Oh, I'm going to say it. I'm actually typing this to Brian. The most successful awareness raising comes from people like Brian. When you have real people, when I talk about my journey, I thought I knew about, I've been in cancer services for 45 years, and I have been advising people, treating, but until I got it, it was a different kettle of fish, basically, especially as I was shocked that it had already gone to 7 of my glands. But Brian coming through it and actually talking about the practical things that he did is the best awareness raising. So I'm encouraging everybody, whether you are a carer, carers have their part as well. You know, one of the women who came to us said she thought she was in a bad relationship before she got with the love of her life, and she thought he'd gone off her because they weren't, you know, intimate anymore. But he was actually treated for a year with Viagra by his GP. He had prostate cancer because one of the symptoms is erectile dysfunction. So, you know, I've had people come and talk about that, and people joke about it. I mean, once we had a man who was in a church, it was a very formal church. Says, my first symptom was erectile dysfunction. And like all the children were asking kind of what does that mean? And this church was very formal. But in actual fact, when somebody like Brian gets up and says it, or, you know, not being able to pee, getting up more than twice in the night to go and pee is a sign. And most of the time it's going to be an enlarged gland. But actually an enlarged gland can be pretty painful. We've had men's glands who've got so big that they've gone up into their bladder, and they've had to have 2 operations to deal with it. So it's really important. Thank you, Brian, and everybody who has presented and welcomed us as well.
Oh, thank you so much.
Thank
I know
you.
that somebody in the chat was asking if you've got any activities down in London. I just want to encourage people, please go onto the BME website, BME Against Cancer website. They have a lot of information. They are a fantastic source, and can we please support them? They've got a page where you can donate, because we need this work to continue. Our community needs to support one another. And if we do this, then we can support our men, support our brothers, our sisters, anybody who's suffering with cancer. So please, I want to take that plea reach out, go on the website, read the reports, read the stories, and donate. I'm just gonna ask one of our members, Minus, to just say our thank yous, and then I will close, because I think it's really, really important that we get one of our executive team just to say one or two words on the executive team's behalf. Minus?
Yeah, good evening. I'm Minus, one of the MUNA exec. Thank you so much. And our vote of thanks goes to Dr. Namero for just giving us an overview about prostate cancer. Sometimes we think we know it all, but I think we don't. These kinds of simple presentations that you've given us has given us some better information that we can actually simplify it to some of our family members, our friends, our patients. So we do really appreciate that. Secondly, Brian, you were so brave coming here, sharing that kind of information to this wider population. It's really, really something that needs courage, but we do appreciate you for coming out and sharing that information to all of us, and to just know that this is a big problem to all of us, and it can happen to anyone, no matter how much we love them or no matter how healthy we look. So thank you so much, Brian, and wish you well, and hopefully everything goes well with you. And I think it'd be nice in future as well to come back and just share us more with this information. And
absolutely, thank you.
Yeah, and to our speakers as well, Mr. Lindsay Thomas and Dr. Rose Thomas. This was brilliant. And also to see like the whole family working together collaboratively, it just tells us like it's good, and to share that information and giving people a voice and that listening ear as well for all the hard work that you're putting there, the charity work that you're doing, and also raising awareness, and also just giving people that voice to locate themselves and to have somebody to listen to them and advocate for them, the support that you're giving. We just pray to God that He should just richly bless you to carry on with this work, and that collaborative work you're doing and engaging with the community. It can't just go without being noticed. And our wider audience, thank you so much for coming and sparing your time to be with us this evening. So now the ball is in our hand. Let's go out there to share this information. Let's not just sit on it. This information, we have our brothers, our sons, our husbands, our men in all these WhatsApp groups. Let's not just be chatting and sharing all these other, it's good to have that social information, but let's have these difficult conversations, because the area we talk about it, we raise awareness. Let us help these people to be open enough to talk about it. And I know it's a private thing, but there are so many other things that we share, like jokingly with each other. Why don't we share these kinds of information to our families, our brothers, our dads, and all those kinds of things? I know it's hard, but I think we are living in an open society now. Let's use that open forum to share this information. So thank you all for coming and for all this information that you've given us. We're going to go out there and also raise awareness.
Thank you so much. Thank you so much, Minus. And my audience, I know we've gone over time, but this is a testament of how important this topic is. And I feel like we've literally just scratched the surface. We haven't gotten to the meat of it. And because of this, I am going to say it here, Dr. Rose Thompson and Lindsay Thompson, we are still going to reach out to you. I feel that this is going to propel into a series where we talk about other cancers. You touched on breast cancer, you touched on lung cancer, we look at leukemia. So going into the future, as MUNA, we want to continue to have these conversations with you and create awareness and look at other ways where we can work together. I've got our president, Charity Gladstone. Charity, do you want to say something very quickly? I know you were off today. You were running around. You haven't met Rose. So Charity is the president of our association, and she is our leader.
Hello.
Charity, do you want to just say hi and then shush? You can close us. I'll let you close the session.
No,
I'll put in the
no.
Oh, Charity.
Thank you so much for bringing this seldomly topic, because as culturally, or whether it's just us, BME, we don't like talking about it, and especially our men. So thank you so much, Brian, Dr. Thompson, Lindsay, and Wanangwa. This is just so invaluable information. We can't wait to share, and we can't wait to work with all of you to raise awareness, because it's there within our community, but not just aware of it. So thank you so much for simplifying it, most of all.
Thank you. So I will stay in touch. Thank you, Charity. I will stay in touch. But once again, thank you. People, website, go. Lots of information on the website.
Sala, well done. Very well done. This was my first one. So very well done.
Thank you. Thank you all for responding to my call. I truly appreciate it. You have made this, I think, a memorable session, and it's a really difficult topic, but you broke it down that people can take it piecemeal and start that conversation, because that's what we need in our community, to start having these conversations, not behind closed doors, but out in the open without any fear of repercussions, and to know that there are support groups out there. So I've seen in the chat, I think it's Lyndon, there are people who want to come and help. So please get in touch. Lyndon, do you want to get in touch with me? I think Rose has written to you. So if either way, we can always make a connection. There are people who do want to come out and help. And Rose and Lindsay, I know they're always looking for volunteers to support them. So that would be fantastic.
Well, at the moment, we're looking for volunteers to help with the gallery blood tests when the mobile vans go around the country. So we're looking for volunteers to encourage people to participate, because unless we get our DNA in there, you know, the cancers that affect us, which I think some of them are slightly different, then, you know, we're not going to be able to develop those tests and those treatments that are specific to us as well. So it's important.
Charity, do you hear that? We're going to pencil something in the diary and see what Muna can do. I am making an executive decision.
Coming to Nottingham in June. So,
okay,
I got it.
I will be there.
Loud and clear.
Okay, well, I'm going to stop recording. People are free